Once you see enough patients who are sick, you start to notice the look of death. I don't know how else to describe it, that ashen look when somebody, and it's not just how they look, but also that you just start to notice they're not quite there anymore. They have a very painful injury, but they're not really that responsive. They're just kind of moaning or making sounds. They may kind of intermittently answer questions, and just their pallor is gone. That it's almost like their life is gone. And sometimes we'll discuss this, like how do you tell someone's ashen if they're a person of color, like a darker skinned Asian person or African American person. But when someone bleeds, they have the same look, regardless of what their skin color is. There's like a lack of red in their skin or like hue in their appearance. And you start to notice those things. And after doing this for this many years, every time I see a patient like that, I already know right away what's going on with them. It's a matter of finding where it is and how to control it, but you already know that bleeding, even without seeing their vital signs or anything. When they roll in, you just know it.
Hello, welcome to Medical Murmurs, where emergency physician Dr. Paris Lovett talks with other doctors about their lives and their work in medicine.
Welcome. I'm talking with Lin Wang. He is a trauma surgeon at Cooper University Hospital in Camden, New Jersey. And thank you for joining me today.
Thank you for having me.
Do you remember any cases that made you think trauma was right for you?
Yeah, there are a lot. I remember as a resident, we had a young man who was at a party, and I don't even know if he was involved in the altercation, but there was an altercation. He sustained a gunshot wound in the abdomen, and I remember him coming in extremis, hypotensive, probably pericardiac arrest. I remember walking around the trauma bay at Lincoln. It's a separate room from the surgical ER. And I remember walking around the corner and seeing the bottoms of his feet on the gurney. And once you saw that, you're like, oh, this guy's got to be bleeding, because it's that same look I was describing before. And, everyone's around him. The nurses are trying to get IVs in him. IV fluids are hanging. And, right away we called for blood, because we knew he had a gunshot wound, so he had an obvious source of bleeding. His abdomen was a little distended, and he was diaphoretic, pale, tachypnic, all the things that line up with someone who sustained a major injury. And when we exposed him, he had a gunshot wound right in his mid-abdomen, so you knew that it probably hit a central vascular structure right away. You knew this guy was in big trouble.
And he had a single entry wound?
Yeah, he had a single wound.
Mm-hmm. No exit?
We flipped him. No, he didn't have an exit.
And did you was the plan just straight to the OR?
Yeah, we're going to get some blood in on him, shoot an x-ray. And I think one of the ED residents did a fast exam, and it was obviously positive. So there was free fluid in the abdomen, which in the setting of trauma is almost always blood, especially I think he was like 23 or 24 years old, young man.
How long do you think it took from his arrival to when he was able to get to the OR?
Probably no more than 10 or 15 minutes. And we were upstairs. There's no place else he needs to go. He doesn't even need to get imaging. He's hypotensive. He can't get imaging. And he has a single gunshot right in the mid-abdomen. So, that's where he needs to go. He had a 10 blade, I remember, and just 2 or 3 cuts. He was at the fascia, and then one more cut, we were in the abdomen. And we were met by a rush of blood from the intra-abdominal cavity. And the first move we do in trauma for any bleeding patient is to pack all 4 quadrants of the abdomen. So the right upper quadrants where the liver is, the left upper quadrants generally where the spleen is, and then the lower quadrants are where the colon and the paracolic gutters are, the pelvis, and the right lower quadrants, the right side where the right colon is, and the pelvis on that side as well. So we put laparotomy pads in there to kind of take up space to tampen out the bleeding, which is to kind of compress it down, to slow it down. We didn't know at the time that it was a venous bleed. And so the packing is really just a temporizing measure to slow down bleeding so that the anesthesiologist can catch up with the blood transfusions because this patient's actively bleeding. So without packing, he would just bleed out into open space and eventually, go into cardiac arrest from blood loss. Once you're able to pack, it seemed like the bleeding slowed down a little bit. And we're able to start kind of looking around the areas that weren't packed. And we noticed right away the patient had looked like a zone 1 inframesocholic hematoma, which is basically a large bulge in the central part of the abdomen where the aorta and the IVC sit, but below the blood supply to the colon. So you knew it was probably a lower abdominal injury. And based on where the gunshot wound was on the abdomen, which is near his belly button, you knew that the missile probably entered low in the abdomen. And seeing that hematoma made us realize that that he was bleeding from a central vascular structure. He kind of knew that ahead of time, but that just confirms it. So we unpack the lower part of the abdomen and get access to that and kind of push the small intestine out of the way. And we started mobilizing the right colon, which is to kind of take the attachments to the right colon off of the back of the abdomen, because that's the first step to removing the kind of the covering over the blood vessels. And once we started exposing that, we were met with a rush of blood from the IVC injury, and then we visualized the injury and knew that was happening. So my attending asked for me, and I think the medical student, to pick up a sponge on a stick, which is a ringed forceps with a wad of gauze at the end of it. And he wanted me to compress above where the bleeding was, and one of the medical students to compress below where the bleeding was, to kind of isolate the flow into that area.
So you're compressing the IVC, the main blood vessel that returns blood from the whole lower half of the body.
That's right. And you could see his aorta. There's a pulsatile, but the flow is obviously weak from blood loss. So once we were able to compress it, the bleeding slowed down. And we were able to have the anesthesiologist give a few more units of blood. And once you were able to catch up and get his blood pressure kind of to an acceptable level, which is in trauma usually 90 to 100 millimeters of mercury systolic pressure, then he attempted to dissect out the surrounding tissue around the IVC injury. So we would periodically kind of let go of our compression to see where the bleeding was, so you could find out where exactly we need to go. And he dissected the IVC free. And at this time, the vascular surgeon came in. She was called in. And once everything was dissected free, we saw the extent of the injury. First, we noted that the aorta wasn't injured, which is good, because with both of them are injured, the amount of bleeding you would get is probably uncontrollable, and the patient would surely die from that. We were able to isolate the injury in the IVC, and there was like a big loss of a big section of the IVC, large enough that it probably wasn't possible to just sew it back, the hole closed. The distance between the free ends of the injured vessel were too great. And the patient was also still hypotensive and still pretty sick. So the decision was made to ligate the IVC, which is basically to tie it off. And this can be done in certain instances if the patients are really sick and there's no time or you're not able to do a formal repair of the vena cava. Patients tolerate that pretty well because there's collateral flow, so they develop collateral flow around that. And also, just you don't have time. They can't be in the operating room for that long, because as patients lose blood, they become cooler, they become coagulopathic, so everything starts to bleed, and it becomes impossible to control without packing the abdomen off and getting them warmed up and resuscitated in the ICU. So the decision was made by my attending and chief resident to ligate the IVC. So the open ends of the injury were oversewn with a stitch to control bleeding. And that whole area was packed with gauze, and the patient's abdomen was actually left open to allow for the bowel to swell and everything else from the injuries that he had. And we also found some bowel injuries too, which we kind of closed with sutures to control contamination so he wouldn't get floor-lead septic while he was being resuscitated in the ICU. And long story short, he went to the ICU, was sick for a while, got resuscitated, warmed back up, and then we came back to the operating room the next day. And given the degree of injury, it was decided that we would just keep the IVC ligated, because it's a low-flow system. Fixing that or like reanastomosing it would probably just result in clot formation, which would thrombose the IVC off anyways. So they thought just leaving it ligated would be fine. And the patient did, suffer some of the sequelae of having their IVC ligated. I remember he developed like lower extremity swelling, but as collateral vessels or flow formed around the area where the IVC is ligated, the swelling went down, and he was able to get up and walk, and he regained bowel function after we did reanastomose his bowel injuries. The second or third take-back surgery we did for him, and we got his abdomen closed. And I think having the gift of youth on his side and probably some luck and skilled trauma surgeons, he made a full recovery, ended up going back to his work. And we saw him 2 or 3 months later, and he's very thankful. He's a nice person, and I think that's when I saw that. That's when I really, really realized how good of a job trauma would be and how much I really wanted to do it. And I think that and my other experiences helped me make that decision.
You are listening to Medical Murmurs.
Did you have any history of doing complicated things with your hands prior to surgery that were a challenge?
Not so much. My father, when he was in Taiwan, he was a teacher, but he was always very good with his hands. And when he came over here, I think with the language issues and things like that, he could never do that again. But he was always very, very mechanically inclined and great with his hands. He ended up becoming a machinist and working as a tool and die maker at a small marine engineering firm in Michigan. And before that, he actually had gone to auto mechanic school and had fixed cars for a while. So we still did a lot of our own work around the house. And that was kind of a time when I was growing up, we were pretty poor. So it was hard to just buy new things. So whatever broke in the house or whatever needed repair in the house, he would be doing it. So I kind of just followed him around and did those things. So I worked a lot with my hands, understanding tools and things like that. I knew it pretty well, even before I did surgery. So I guess in that way, that was always part of my life. And as I got older and things got a little bit better in the household in terms of our financial situation, we didn't do that as much anymore. But it was always a part of me because I grew up with it.
So could you tell me a bit about, firstly, your background and how you decided to go into medicine?
Well, I grew up in Michigan, but I immigrated to the United States in 1979 from the island of Taiwan, which is off the coast of China. And I grew up most of my life in Michigan. I didn't really have any thoughts about wanting to go into medicine at the time when I was growing up. And I started out and thinking about doing engineering. I actually originally wanted to study military history, but my parents put the kibosh on that right away. So throughout college, I realized a couple of things. Number one is my math's really not good enough to do engineering. And as my college career went on at the University of Michigan, Ann Arbor, my interest in the biosciences grew. So I tried my hand at working in the lab, maybe doing some genetics research. And that didn't quite do it for me. I thought it was a little too esoteric. And it's kind of ironic now looking at medicine, how much more of a genetic component there is to modern medical care. How those two roads kind of cross paths again. But, after working in the lab, I still had the keen interest in the biosciences. And I thought to myself, well, what am I going to do with my life? I'm, 4 years out of my undergraduate degree. And one of my friends I was talking to him one day and he was like, did you ever think about doing medicine? I'm like, that's actually not a bad idea. I started looking into it. Did a couple of the prereqs I didn't have to apply for medical school. And then after that, I applied first to U.S. medical schools, especially the ones in the area around Michigan. Didn't really want to leave the area so much at that time. And after being waitlisted, having interviews, being waitlisted a couple of times, my friend, the same thing happened to him as well. And he had gone to St. George's in the Caribbean, Grenada. And he's like, it's not that bad here. You should consider coming here. And if you still really have it in your heart to do medicine. And at that point, my conviction to do it was much stronger. So I took him up on his offer and applied, got in, and off I went.
Where?
In St. George's University in Grenada, West Indies.
So what was it about trauma that drew you?
Again, I think there's a common theme. I like surgery for the fact that you get to use your hands. And I think trauma is an extension of that because you make rapid decisions and this goes back to the case I saw as a medical student. Someone's dying, you like reverse their course and get them better. I think that was very appealing. I like the decision-making environment. It's very rapid and there's no fluff or anything to it. You just need to make all the decisions that need to be made to sustain this patient's life, to get them to the operating room or get them to interventional radiology or wherever they need to go to have their problem addressed. That really appealed to me. And I also like the fact that you just took care of whoever's in front of you. You didn't have to see if they had insurance or do these other things. I really dislike that part of medicine a lot. I wish it wasn't a part of medicine. People just got taken care of for the problems that they had instead of having to get referred somewhere else because of insurance status or whatnot. I really dislike that. So I really like that part of trauma as well. Take care of everyone, regardless of who they were or like, whether they could pay or not, whether they were undocumented alien or whatever, it doesn't matter. I think my perception of what medicine is healing with your mind and with your hands. And the healing with your hands component isn't as prevalent in internal medicine. And it's a great field. I have nothing against it. I think that people who go into it, they do a great job. But it just didn't seem to have it for me. I think the pace of it wasn't as conducive to my thoughts about how medicine should be. But surgery fulfilled all those things. I think mostly the work and the pace, the non-procedural aspects of it, even though GI itself is a very heavy procedure-based field, it tends to be the same procedures over and over again, and they don't tend to be as complex as a surgical procedure would be. And that really appealed to me, the complexity of surgery and the pace at which it moved.
You are listening to Medical Murmurs. If you enjoy this podcast, don't forget to review us on iTunes and other forums. You can also visit medicalmurmurs.com and sign up to hear about new episodes.
I was wondering if you could take me through to a case, maybe a more recent case that has stuck with you, and what seemed like the early decision-making and how things shifted, how it played out.
Yeah, so we had a recent case. It was a bad motorcycle accident, and the patient comes in, and oddly, doesn't look like there's anything wrong. There's not a scratch on him, but he has the look of someone who's bleeding. And one of my favorite lines is, there's 3 reasons why patients die from trauma. And it's kind of a joke, but it's kind of true at the same time. Bleeding, sanguination, and hemorrhage. Right? Bleeding is almost always the most common cause. It's the most common cause of death in the trauma patient. And as a trauma surgeon, you are almost pathologically inclined to look for bleeding. And so we go through our ABC disease, our primary assessment of the trauma patient, and secure his airway because his mental status isn't great. So perhaps he has a head injury, and we stabilize him, get blood into him.
Can you sort of maybe start with, what you were told about the accident and what he looked like when you walk in the room? What you kind of, the initial impression?
Yeah, so we're told that he was in a bad motorcycle accident. He was hit by a car, and he was found like 50 or 60 feet away from his motorcycle, like ejected from his motorcycle on the road. Not much blood loss, no blood loss at the scene. At first a little combative, and then more somnolent, more sleepy. And his vitals in the field, his heart rate, I remember, was in the 120s, but his blood pressure at the time was like 120/80. And he came in, and when he arrived, he had that ashen look to him, like he had lost some blood. And so right away, I'm thinking, this guy's losing blood. Even though his blood pressure is normal, he just hasn't registered the change yet, I think. He's lost enough to start looking like pale, but hasn't lost enough to drop his pressure. And he's also a younger person, so he has some reserve. So he's able to kind of clamp his vessels down and maintain his blood pressure longer, I think, than someone who's older or like more debilitated. And we went through our paces trying to figure out where his blood loss was. And we do this by getting a chest x-ray, a pelvic x-ray, and a fast exam, which is an ultrasound of the abdomen and the heart to see if there's any blood around the heart, which is uncommon in blunt trauma. But what's more common is having blood around the liver or whatever on the ultrasound. And oddly, the first ultrasound was negative for any free fluid in the abdomen. And as we had him longer, his blood pressure started to go down. He dropped from 120s to 90s and then to 80s. And so that triggered us to give blood through his IVs that were placed by one of our nurses. And as we resuscitated him back up, we did a fast exam again, and still negative. And he's a young person who's never had an operation before. A normal body habitus, so it should be a fast that we would see fluid in.
If you've got someone that you're convinced has lost blood, because as you've said, the pressure's going down, their heart rate is elevated, and they have that gray look to them. Mm-hmm. The abdomen is often one of the prime suspects.
Yeah.
And the other areas would be?
The abdomen, the chest, the pelvis, which is, I think, a kind of a forgotten source of blood loss, but it's a potential space. But if you bleed from your pelvic vessels, it can create a space where patients can lose quite a bit of blood. Long bones, the femur in particular, and the field, which is like any cuts or injuries that could result in blood loss outside the hospital that may stop from like vasospasm, the blood vessels spasming down, which you may not notice active bleeding when they come in, but they've lost a ton of blood in the field. So a common question we ask our EMS practitioners is, was there a lot of blood loss in the field? You know, and in this guy's case, I mean, there were no cuts on his external body, so there was no blood loss in the field. You could see that.
And because you've done a physical exam from head to toe, at this point, you're pretty convinced he doesn't have a femur fracture.
Yeah.
So he's not bleeding into his thigh. And you've examined his pelvis. And
yeah, at this point, we had x-rays of his pelvis, and the pelvis looked pretty normal. And we had a chest x-ray, and the x-ray looked pretty normal as well. So we knew we had ruled out most of those injuries there. So the only place we hadn't ruled out an injury is in the abdomen. And so I ordered my resident to do another fast exam, and I sat there and watched him do it. And a lot of our, one group of residents that rotates with us are the EM residents, and they're extremely good at doing these exams. They're very efficient. I think they basically pushed the ultrasound technology forward more than surgeons have, and we've kind of adopted it on their coattails, so to speak. And I watched him. He's a really, really good resident. I watched him do it, and it was clearly negative. And I actually did a few of the views myself, and looked negative as well. So at this point, with the resuscitation that we were giving him, he recovered his blood pressure back to 120, 130 systolic. And I made the decision to take him to CT scan because we didn't find a distinct source of bleeding. But the suspicion is that's in the abdomen. It's just somehow it's either in the retroperitoneum or we're not getting a good look with the ultrasound. So he went to scan.
And do you mind, before you go to scan, I mean, I think our specialties, emergency medicine in my case, and trauma surgery in yours, think hard before we send a trauma patient who seems sick to the CT scan.
Yeah, it's a big break in the patient's care because they leave the relative safety of the trauma bay and they go off to a scanner. And if you've ever seen a CT scanner, logistically, it's a very quick study. It's like a 5 or 10 minute study. So it doesn't seem like it's much time, but getting the patients there takes it's near us, but it takes 5 or 10 minutes to get them there, get them on table, and get the scans done. It's probably like a 20, 30 minute process. And we're very efficient at doing them. We do hundreds of scans a night. So our technicians in this CT scanning room are really, really good. And even with that, I think the fastest we can get a patient in and out of there is like 15, 20 minutes probably. So there's quite a bit of time, and it doesn't seem like much time, but it's an eternity in trauma. Because remember, in trauma, they talk about the golden hour. So that's 1/4 to 1/3 of the golden hour, not to mention the fact that the patient took time to come here. So now you're getting near your golden hour where you have to make diagnoses and figure out what's wrong with the patient. And when we scanned him, he had this terrible spleen and liver injury that the liver, I think the majority of blood loss probably from the liver injury, and a lot of bleeding in the posterior part of the liver near the retrohepatic IVC, but not quite in it based on our scan. And oddly, there wasn't fluid around that area of the kidney, which to this day I don't understand. But we have the saying in this field, sometimes the patient doesn't read the book. So from there, seeing that, and then his pressure started to kind of drift down again, we knew that we needed to go to the operating room. And unlike the spleen, the liver obviously is essential in an adult. You can't just remove it. So our plan was to pack the liver with gauze to kind of compress it down to stop this bleed, and to address the spleen with a splenectomy, because it's a grade 3 spleen, so there's active bleeding in there as well. So I think the hypotension was driven from primarily the liver, but a combination of both the organs bleeding. And so we took him to the operating room, took care of the liver. There was also like a bowel injury as well, so we controlled contamination and packed the liver.
And so when you open up the fascia, what do you see?
Blood. Blood just pulls out of the abdomen, swelling up everywhere. And the same maneuver we always do, we pack all 4 quadrants with gauze. But while you're packing, you kind of get a feel of things, and you start feeling the uneven surfaces of the liver that's injured. And so we pack the liver down really well. And we packed the spleen down as well. And since we had a scan, we had some idea of what was going on. Most liver injuries are managed with packing and allowing the organ to kind of stop bleeding on its own. So once you pack the liver, it looked like most of the bleeding stopped. So we went up to the spleen, packed that as well, and we unpacked, since the spleen generally isn't essential, to prevent it from rebleeding. We usually do it, if we're in the abdomen, we usually do a splenectomy. So he had a grade 3, grade 4 splenic injury with active bleeding. So we did a splenectomy, controlled that, ran the bowel, which is kind of our term for looking through all the small bowel, making sure there's no injuries, looking at the large bowel.
And that means basically passing the bowel, which is a tubular structure, through your hands.
Yeah, through your hands, and flipping it over and looking to make sure there's not a tear in the bowel itself, where there's bile that can leak out and cause contamination and sepsis in patients.
And the big deal here is that inside someone's abdomen is, and has to be, a sterile space.
Yeah.
And if the bowel has a breach in it, it's different from some other organ being breached.
That's right. Patients will tolerate blood in their abdomen fine. They won't have any issues with that. But if they have bile from enteric contents, what's in the bowel in there, within 6 to 12 hours, they're going to get really, really sick. And so that contamination needs to be controlled. The other thing we look for in trauma, Ashley, is a disruption of the blood supply of the bowel, because the blood supply travels up a curtain of fat, so to speak, that's connected to the bottom of the bowel. And if there's a tear in that fat and the blood supply to that section of bowel is disrupted, over the next 6 to 12 hours, that section will die. And once that section of bowel dies, then it'll perforate and the patient will get sick again. It'll happen in delayed fashion, which is like very, very difficult to manage, because a lot of times the patient's abdomens will be closed, and when they get sick, they'll present very much like somebody who has a SIRS response, a systemic inflammatory response to trauma or injury. So the diagnosis is usually delayed. And since the abdomen has been open before, if it's not addressed, there's still air and free fluid in the abdomen. So those are the telltale signs you look for bowel injury. But since you've already opened the abdomen, it's hard to tell whether it's from the bowel or from the abdomen had been previously open. So those are definitely things you don't want to miss. So this is the kind of injury that this patient had. And so we resected, or basically removed that section of bowel that had no blood flow. You can already tell it's starting to look different from the other bowel there. And with the thought that we would come back in 24 hours time to unpack the liver and make sure it stopped bleeding and fix that bowel injury. And as it turns out, after surgery for liver injuries, we generally send them to interventional radiology, even with the packing in, and have them, colloquially we call it squirt the liver, but basically they inject IV contrast into the liver and look for any arterial bleeding, which he had a little branch, which they end up embolizing. And over the course of the next few days, the patient slowly recovered. And eventually we took him back to the operating room, I think 24 hours later, and unpacked his liver. And there was no longer bleeding there. With the embolization and the compression of bleeding, it stopped. We left a few drains in because the liver not only has blood in there, but it also produces bile, and it's very irritating for the abdomen. So we leave some drains to kind of address that. And as the liver heals, it heals itself. So you don't really need to do much to that. And eventually, I think he had some lower extremity. He ended up having like a tibial injury, fracture, and he ended up going to the operating room for that, and ended up going home. I did okay. I haven't seen him since this happened more recently, but hopefully he comes back to visit us if he's doing well.
I have, unfortunately, occasionally had cases where it got away, you know. I was wondering if you could talk about one of those cases, not necessarily one where there was anyone at fault, but just one where you went in thinking maybe you could save someone. And as you went on, it slipped away from you.
Yeah, I think everybody who takes care of someone who's acutely ill probably has stories that pertain to this. And as one of my mentors said, but I'm sure it's not something he thought of, but he's like, every surgeon has a little graveyard that they visit from time to time. I think it's not good to dwell on those things, but it's also not good to not remember, because I think there's a certain amount of education that you can garner from good cases, and a lot of education you can garner from bad cases as well, or things that didn't work out the way you thought they would. And I think remembering those lessons is important for taking care of your future patients, but also for just respecting the sacrifice of like another patient that was made for whatever reason. Part of what I do here is acute care surgery as well. And there are a lot of patients who come in with, bad surgical problems like bowel perforations who are so physiologically ill. Even if you're able to fix that problem, they physiologically ultimately can't recover from the septic component of their insult, so to speak. But I remember a case pretty well as an attending of a person who was sent over with what was thought to be perhaps a splenic injury. The patient had a really remote history of falling and was a not healthy older woman, I remember. When she came over here, she was first seen at the outside hospital probably like 10 or 11, 12 hours prior to her arrival here. And I just remember thinking to myself, when they called me and said, this patient needs to come over to you, and because we don't know what's going on with her. So I remember thinking to myself, okay, we'll take her over here and do what we need to do. And long story short, she came over here, and by the time she came over here, she had that same look of anyone who's bleeding. And it was obvious that she was bleeding, and her pressure was really low. She was kind of also, I think, peri-arrest from blood loss. And so we took her up and, did her surgery, and realized right away she had nothing to do with trauma or spleen. She had ruptured like an aneurysm in her superior mesenteric artery. And before we could even get control that or get like a vascular surgeon here to help us with what we could do, she had probably lost so much blood along the way. It was like an unsalvageable situation, and we lost her, and that was a really difficult case to deal with as a junior attending, So I remember that case pretty well too.
What did you see when you opened her abdomen?
It's blood everywhere. So you don't see where the injury is. And then as you start exploring and looking, then you realize where the injury was. And that's a very, very difficult place to access. I think people operate on the superior mesenteric artery electively, but there's no blood in the field necessarily. They may expose the aneurysm or do a procedure there, a bypass or whatnot. But having to operate on it with a big hematoma in the area and active bleeding coming from that area, that was very difficult.
So you put in the packs as per usual.
Yeah.
You suctioned out or evacuated the clot.
Yeah, suctioned out, evacuated the clot, and there's a large hematoma. So we started out by moving the left colon over because the hematoma seemed higher. And to expose the higher part of the aorta, you have to move the left colon, not the right, as opposed to the IVC, a lower part of the inferior vena cava. And we're able to expose the base of the vessel. But in terms of where the bleeding was coming from higher up. and it was a rupturing aneurysm. So the tissue there was very friable and thin. It wasn't like a normal vessel that just had a cut in there. That would have been a lot easier to fix. This was really difficult because the aneurysms are quite large, and trying to find the ends of where the vessel is bleeding from was actually very difficult. And so we called vascular surgery to help us kind of at the beginning of the case. And they got here in pretty timely fashion, but I think from the loss the patient had and the fact that she was a little older and probably had other health problems, I don't think her heart could take that amount of injury, amount of hypotension. So she went to cardiac arrest and died.
You are listening to Medical Murmurs.
A question that often comes up amongst, I would say, non-doctors as well as just non-surgeons is, how do you know if a surgeon is good?
I think there's a public perception that, good doctors are like cocky or like ultra confident. I think sometimes the best doctors are the ones that relate to you the best, and they act like a normal human being. Most of the best clinicians I've worked with are like that. I've worked with a few clinicians who are like super cocky, who are good at what they do, but I would say that's generally the exception, not the rule.
Let it be comforting if we can judge the book by its cover.
I think you can somewhat. You get a idea of how the person is. I think that's more important than like all these scores that are out there or ratings or, because I know for a fact I'll look through sometimes and I know someone who's a good clinician, they may not have like the best patient satisfaction scores. And I'll know a bad clinician, they have great scores. I think that's one of those things where if you pay a lot of attention to it, you can make those however way you want. So it's not really I don't feel that as good of a way of judging. I think word of mouth, your impression of when you meet them, I think those are the best things.
How do you deal with it?
We have services here that help us deal with it. Human Resources has like a team that will come and talk to the caretakers or the trauma team that took care of a difficult case. I think you get over from going back to your support system, your family. I think it's a big part of it. I tell my residents all the time, the ideal job is the job that you take, that you like what you do, and what makes the job work is having a good family life. That's extremely important. I think not having a good family life, even if you have the best job in the world, it'll make the job seem like it's the worst job ever. And I think this is part of the reason why, because that's your support system. I think a lot of physicians don't realize that, or they may realize it but never say it, but that's what keeps you sane. And I always tell my residents, I care about my family because, number one, you should. If you decide you're going to spend your life with somebody or you're going to be someone's father or mom, you should care about those things. And the second thing is, you're only a doctor for a set period of time. After that, I'm always going to be my daughter's dad, so that's never going to change. So you should take care of those things. I think that's where the field could change for the better. And I think, even though I hear this from my older attendings a lot, they're like, oh, in this generation, they care about their lifestyle and everything. I think you should care about those things. If you care about those things like a human being, you'll act more like a human being to your patients. It doesn't mean that you're less dedicated to their care. It's that you have more balance in your life, right? Your family life is balanced with your work life. So if you're happy in your family life, you tend to be happier in your work life. I really believe that. I think that's really important. I try to tell my residents and medical students that all the time because they get to the decision-making process that I was in like 10, 15 years ago. And they may be in a different point in their life. Maybe they're not married yet, or like they don't have any kids. And so they don't understand how important that is. I try to tell them that because I think that's what mentoring is. It's not like telling them, oh yeah, surgery is great because you get to operate on people all day. I think it's you tell them that, but you also tell them the flip side to it. You don't want to be the reason why they don't do something. You give them such a bad experience, they don't never want to do the field because of the experience they had with you. But you also want to give them an honest look at what your profession's like. And one of the most important things I think they need to learn, because for someone who's, I mean, you know this because you're a physician as well, they're so like goal oriented, they forget about the other things in their life that are important as well. I think sometimes doctors forget that how important it is to have a good family life, and how much that interplays with your professional life. It's very important.
Thank you very much for taking the time to talk. It's been fascinating.
No problem.
I really appreciate it.
Thank you for your time.
This is Medical Murmurs. If you're a medical student or just interested in medical careers, there is another episode with the same guest, where we focus on career questions such as how best to get into a specialty and develop a career. It's called Medical Murmurs Medical Student Edition. Check it out.